hello, everyone. My name is Beth Johnston. I'm the Chief Community Engagement Officer here at the FSHD Society. And together here with Jun Kinoshita, our Director of Research and Patient Engagement, we'd like to welcome you back to our FSHD University Educational Webinar Series. And for those of you who don't know us, the FSHD Society is actually the world's largest research-focused patient advocacy organization. That is such a mouthful, but we are focused solely on FSHD. We've got 33 chapters across the US and now in Canada. We are part of a 20-country World FSHD Alliance, and our mission is to find treatments and a cure for FSHD while empowering our families. So we host these and so many other events to give you, our families, an arsenal of knowledge so you can be your own best advocate when it comes to your care, and to empower you to better understand the research and the role that you can actually play in accelerating therapy development. So this is the time for all of us to activate in research, in community, and in self. So today, from our research department, we welcome our very own Miss Heloise Hoffmann, who will share her work focusing on understanding the relationship between FSHD, sleep, and pain. Heloise is actually an FSHD patient who really feels passionate about activating the community. And this led her to become the leader for the Southwest Florida chapter and to take part in an initiative to maximize youth involvement in FSHD. So she really strives to get involved in science and research for FSHD. But I'd love for June just to properly introduce Heloise for a second and maybe talk a little bit about her study.
Okay, so at the risk of making everybody else feel completely inadequate, Heloise is a senior in high school, and the talk she's about to present was begun as her AP kind of biology, I think, project, and it's a great example of how we are all part of the solution for FSHD, because she picked a subject where there has not been a great deal of research, which is on the role on sleep in people with FSHD, and in order to carry out the study, she designed a survey with a lot of wonderful advice from people like Dr. Jeff Statland, who's a leader in the field. And then that survey went out through the FSHD Society to all of our members. And I think something close to 700 people responded. And this is really, really important that you did. I hope many of you are out there in the audience who responded, because this is how we're going to move the ball forward on understanding FSHD. It's you who are living with this condition are experts in your own experience. And we need to come together. We need to share that information. We need to turn that information into data. And then people like Heloise, can analyze it and gain insights that can help drive additional research, ultimately leading to better treatments for us. So your doctors understand, like it's not just one patient here saying they're having trouble sleeping or someone else, which are all one-off, but when all of you get together and say, this is actually collectively what we're seeing in our community, then that becomes something that can change the way doctors understand the disease and then how they manage your issues. So it's really important. And so I thank everybody who took part, and I especially thank Heloise for having the initiative to identify this as a subject and then just run with it. As you will see that she's really run with it. So with that, I will turn over to Heloise, and you can share your slides.
Thank you for that introduction. Let me go ahead and share my presentation here. All right, well, my name is Heloise Hoffmann, and I'll be presenting to you the results of my study on sleep, FSHD, and the role that pain plays in sleep and FSHD. So thank you, June and Beth, for that little introduction. But just again, my name is Heloise, and here you can see a picture of me with my family during last year's Walk and Roll to Cure FSHD. I was diagnosed when I was 13 years old, so I do have, a pretty personal connection to FSHD. And 2 years ago, I became the Southwest Florida chapter director because I truly believe that through activism, fundraising, and research, we are going to find a cure. I'm also part of the Gen Z FSHD movement to maximize youth involvement. And I strive to get involved in research wherever I can, still being as a high schooler. But so I do that through the project that I'm going to be presenting to today. And also I conducted an internship this past summer with the LEC lab at Yale, in which I characterized the DUX4 sequences that are responsible for FSHD. But so we can get into the project now. So I took a course last year called AP Research, and I of course knew that I wanted to focus my research on something related to FSHD, because this was my opportunity to make a difference in the fields that I'm so passionate about. So I reached out to some clinicians to find some fields that they had heard patients commenting on. And one of them, Dr. Padberg, reached back out to me and said that some patients had noted sleeping troubles, and that this had been kind of under researched. So I found that really interesting, because I've actually myself experienced some troubles in the past, falling asleep and staying asleep, and just feeling fatigued during the day. So I'd never thought to link it with FSHD. So I thought that this would be a really interesting path to follow through with. So I then connected with Dr. Jeffrey Statland and Dr. Suzanne Stevens from the Kansas University Medical Center. You may know Dr. Statland. He's of course very prominent in FSHD research and care. And so that's where the project really was born. I of course did some preliminary work and literature review to connect FSHD kind of to the pre-existing field, to see where the research was at in terms of FSHD and sleep, and discovered that sleep distorted breathing and nocturnal hyperventilation were very common in FSHD, most likely due to the fact that as the chest muscles weaken, the respiratory functions could be affected. So this kind of brought on some breathing related sleep disorders. There were also some clinical links that to obesity, anxiety, and pain that had been kind of hinted at through research. However, all of these studies had some major limitations, in the sense that they all used pretty small and selective samples. I think the largest study had only 51 subjects, and most of them were pretty selective based on age and the pre-existing sleep conditions. So there was really something lacking in terms of a large and generalizable sample of patients that could provide insights to sleep quality and sleep aspects in a generalizable population of FSHD patients. There was also no sufficient data on self-reported characteristics of sleep, which are actually really important, because we often focus on the clinical side of things, but patient-reported insights can really provide some insights that clinical assessments can't, in a doctor's clinic. So this is really the gap that I intended to fill with this research study, which led me to the research question: do individuals with FSHD experience reduced sleep quality and excessive daytime sleepiness? And you may notice in this question that there are two aspects of sleep: sleep quality and daytime sleepiness. Through my preliminary literature review, I noticed that sleep quality and daytime sleepiness were not necessarily the same linked aspect, because patients may be able to accurately report how fatigued they feel during the day, but not be able to accurately report events that happen during sleep. And likewise, they may not be feeling sleepy during the day, but still be experiencing reduced sleep quality. So both of these aspects of sleep were pretty crucial to forming an understanding of self-reported sleep in patients with FSHD. So the goal of this present study was to achieve a large sample of patients that could be potentially generalizable to the whole population to determine self-reported sleep assessment in patients with FSHD. So I conducted a survey I designed a survey with the guidance of Dr. Statland and Stevens with 4 sections. The first 2 were demographic and clinical information sections, and then it also comprised the Pittsburgh Sleep Quality Index and the Epworth Sleepiness Scale. Both of these sleep questionnaires have been thoroughly developed and researched when they were produced to determine, to ensure that they were standardized and generalizable and really accurate. So, these two questionnaires have been used in countless sleep studies, and they're really reliable. So this is why they were the best tools in my study to use to determine sleep quality and daytime sleepiness. Through the FSHD Society patient database, I obtained 690 patient responses, which was really, really amazing because that opened up the possibility for a generalizable sample, because when you're working with that big of a group of responses, if the demographic and clinical characteristics match up, then it's possible that those results could be generalizable to a whole FSHD population. So if you filled out the survey back in February, thank you so much, because again, that opened up the possibility for this representative sample that I'm going to get into in just a second. So in fact, those 690 responses did amount to a representative sample. Here on the screen, you can just see some of the data that came from the demographic and clinical sections. The gender distribution was 50-50 between males and females. 2 patients were non-binary, but this was not enough in a sample of 690 to affect the 50-50 distribution. And of course, this aligns with the even gender distribution of FSHD. 44% of respondents were aged 45 to 64 years old, which reflects the progressive nature of FSHD. 37% of respondents were aged 20 to 39 years old when they were diagnosed, and this kind of aligns with a typical window of diagnosis for FSHD. And 25% exactly of patients reported using a wheelchair frequently. And as you may know, around a quarter of patients with FSHD rely on a wheelchair. So based on these demographic data points, you can really see that this sample was representative, which allows these results to be generalizable to the FSHD population as a whole. The most important part of this study was, of course, the sleep assessment as a whole, the self-reported sleep assessment. So here you can see that 66% of patients had reduced sleep quality, as indicated by a score on the Pittsburgh Sleep Quality Index of above 5. The Pittsburgh Sleep Quality Index provides a score between 1 and 21, and a score above 5 indicates reduced sleep quality. The Epworth Sleepiness Scale, on the other hand, gives a score between 1 and 24, and that a score above 10 on the Epworth Sleepiness Scale indicates excessive daytime sleepiness. So you can see that 66% of patients experienced reduced sleep quality, while only 15% had excessive daytime sleepiness. So in general, patients had reduced sleep quality, but typical daytime sleepiness, which is a pretty important finding to keep in mind, because that means that patients might generally be feeling fine during the day and not necessarily be feeling overly fatigued, but actually they might be experiencing lowered sleep quality without knowing it because they aren't feeling those effects of fatigue during the day. I wanted to determine if they were statistically correlated. So I conducted an R-squared regressional analysis. What this test does is just take 2 variables, in this case, the Pittsburgh Sleep Quality Index score, which measures sleep quality, and the Epworth Sleepiness Scale scores, which measure daytime sleepiness, and correlates them to determine to what extent they are correlated, or if they are significantly correlated at all, meaning as one increases, the other increases, or as one decreases, the other decreases. And in fact, they were significantly correlated, although not to a great extent, meaning that typically as sleep quality decreased, daytime sleepiness increased. I then drew some correlations between the demographic and clinical sections to the sleep assessments to determine any factors that might be influencing the sleep quality or daytime sleepiness in this population with FSHD. So the main and most important finding was the connection between pain and sleep quality. To determine all these correlations, I conducted one-way ANOVA tests, and these are slightly different than the test that I just described. These one-way ANOVA statistical tests take one dependent variable, in this case, either the sleep quality or the daytime sleepiness, and then determine to what extent a independent variable is affecting the sleep quality or daytime sleepiness. So in this case, with the pain, within the pain group, there was a group that did not experience daytime sleepiness, and there was a group that did. There was a group that did not experience pain, and a group that did not experience nocturnal pain. So it determined whether there was a significant difference in scores between those who did or did not experience nocturnal pain. And here, through the eta squared value of 0.192, statistically, you can see that this was a very large effect size. You don't have to know all about ANOVA tests, but the 0.192 definitely indicates a large effect size of the pain on reducing sleep quality. This finding was really pretty significant because if you're an FSHD patient or caretaker yourself, you might know that pain is a really prevalent symptom in FSHD, and it can sometimes be kind of hard to find a great solution to get rid of that pain. But this finding suggests that treating pain could not only help help patients lead fuller lives, but could also alleviate reduced sleep quality, because having pain actually has such an adverse effect on the sleep quality. I drew some other correlations as well. First, the existence of a pre-existing sleep condition had a medium effect size on reducing sleep quality. This means that those who had conditions like insomnia, restless leg syndrome, narcolepsy, sleep disordered breathing, etc., had more significantly reduced sleep quality than those who did not have pre-existing sleep conditions. Of course, this makes logical sense when you think about it, that if someone has a pre-existing sleep disorder, that they would have lower sleep quality. But this could actually also be indirectly correlated to FSHD itself, because a lot of those sleep conditions that were listed have actually previously been linked to FSHD in previous research, including sleep disordered breathing, nocturnal hyperventilation, and obstructive sleep apnea. So, this FSHD could actually be indirectly the cause behind the reduction of sleep quality in this case. The next correlation that I drew was between those who had night shifts and daytime sleepiness. So those who had work hours at night had significantly reduced, significantly more daytime sleepiness during the day than those who worked during the day or did not work. Again, this makes sense that those who are working at night would feel more sleepy than those who are not working or working during the day. But taking into account all the other troubles that patients seem to experience with sleep based on this study, it might be wise as a patient to, if possible, consider a day shift rather than a night shift, if that's something that's possible, just to kind of help mitigate all this, the plethora of sleep problems that seem to be present with FSHD. I also correlated age and gender with both sleep quality and daytime sleepiness. And the significance of those results came out pretty similar. Neither age or gender was a significant predictor of daytime sleepiness, but they were both small, significant predictors of sleep quality. So for age specifically, as the populations got older, sleep quality was more significantly reduced, with a small effect size of eta squared of 0.022. This means that as patients' age advanced, their sleep quality deteriorated. So maybe patients in older populations should monitor sleep more closely than those in younger populations. Similarly, for gender, there was a small effect size based on gender on reducing sleep quality. It's females and non-binary patients that had the highest Pittsburgh Sleep Quality Index scores. In fact, the mean score of non-binary patients was so high that I actually recalculated the significance of this correlation using just the female and male populations, and the difference was still significant. So therefore, Females and non-binary persons seem to have more reduced sleep quality than males did in the study. So therefore, females and non-binary patients should maybe pay more attention to sleep habits than males. Another few correlations were the age that someone was diagnosed with FSHD with both sleep quality and daytime sleepiness. Neither of these tests actually came out significant, which was pretty interesting because early onset FSHD is diagnosed typically within the first 10 years of age, but the difference was actually not significant on reducing sleep quality or daytime sleepiness. So this means that even though early onset FSHD patients tend to have more rapid progression and more severe progression, this did not impact sleep or daytime sleepiness in a negative way. Similar situation with with the use of a wheelchair. Using a wheelchair did not have a significant impact on reducing sleep quality or increasing daytime sleepiness either, which was, again, a bit surprising because I was expecting that patients who may be more severely affected might have some more difficulty with sleep quality or daytime sleepiness. But according to the non-significance of these tests, this was not the case. With ventilatory support, there was not a significant effect either on sleep quality or daytime sleepiness, which initially surprised me for the same reason, because patients on ventilatory support tend to be more severely affected. But actually reflecting upon this, it kind of made sense because some of those breathing related sleep disorders that had been linked to FSHD, including sleep apnea and sleep disordered breathing, had actually, like, if they're being treated using ventilatory support like CPAP, bipap, or oxygen, it makes sense that the sleep quality and daytime sleepiness would stay constant rather than being negatively affected if those sleep disorders are being treated. Finally, I'm sure you may have heard before that using a screen 30 minutes before bed could negatively impact sleep quality. So I wanted to kind of test this out in this study, but actually the test did not come out significant. So in this study, the use of a screen 30 minutes before bed did not have a significant effect on reducing sleep quality, which was quite interesting and surprising to me at first. But then again, when reflecting on why this could be, I determined that it's possible that this test would have come out significant in a typical healthy population without FSHD, but that having the FSHD itself actually overpowers that effect, because having FSHD itself could already impact sleep quality to an extent that the use of a screen 30 minutes before bed would not have an overpowering effect. I know I just threw a lot of information at you with all of those correlations and statistical tests, but I hope that you learned something interesting from it. So I just want to summarize some key points so that you have something to take home and remember from this presentation. So generally, in the study, FSHD patients tend to experience reduced sleep quality, but typical daytime sleepiness, which is very interesting due to the implications that patients may not be feeling sleepy during the day, but still be experiencing reduced sleep quality. Pain had a very large effect on reducing sleep quality, and this should definitely be kept in mind in the future in terms of research and treatment options. And because this research was so new, and this was the first large-scale study exploring self-reported sleep aspects in patients with FSHD, a lot of new insights arose from the study, so it has a lot of implications. But there are three main groups that these results really affect. First, patients and their caretakers should monitor sleep quality more closely, because as we can see from this study, FSHD patients could be predisposed to experiencing reduced sleep quality. However, this doesn't mean just tracking how sleepy patients are feeling during the day, because as these results suggest, the two are not necessarily correlated hand in hand. So patients should monitor sleep quality specifically, especially older patients and females and non-binary patients. Doctors and medical professionals should focus more on sleep during care, because of course sleep is always like an aspect of care, but up to now we didn't know how much FSHD patients were actually affected in terms of sleep. And sleep is obviously a very important aspect of one's life, not only in a typical healthy individual, but especially in FSHD patients, because sleep is really the time that patients' muscles can kind of recuperate and rest, to kind of protect from any further damage during the day. So if sleep quality is being lost, this could have some pretty negative implications. So doctors should definitely place more focus on sleep in care, especially on those older populations and females and non-binary patients. Also, they should give more resources to patients in terms of pain management, because of course, dealing with that pain that's present in a lot of patients' lives could not only help patients lead fuller lives, but also potentially better sleep quality. The FSHD Society itself is always great about posting resources and blog posts and research updates. And they have posted pain management resources before, but continuing to do so can again help patients find good options to treat their pain, not only to lead fuller lives, but also to have better sleep quality. And again, as I mentioned, this research opened up a lot of new paths, because this large-scale study had never been done before for FSHD and sleep. So it was pretty hypothesis generating with all those connections that were found. So now all those connections could actually be analyzed in the clinical setting now that they've been discovered through the self-reported setting. But really the most important path for future research would be to analyze the physiological effects of pain on sleep, because although this has been kind of looked into before, further understanding the effects of pain on sleep on the physiological level could kind of revolutionize treatment options and options for sleep care. So that's all I have for you today. Thank you so much for listening to my presentation, and I really hope that you learned something from it. And thank you so much to the FSHD Society for having me on FSHD University today. I'm open to any questions now.
Thank you so much for that really terrific presentation. We do have some questions here, so let me start asking them. So let's see, Rick asks, if sleep quality is not necessarily related to daytime sleepiness, then what is related to daytime sleepiness?
That's a really interesting question. My study definitely looked at like the self-reported aspects and looking at correlations between the sleep quality, daytime sleepiness, and other external factors. But it would be really interesting to actually analyze what is behind daytime sleepiness, because this study couldn't really go into that because it wasn't in the clinical setting. So I couldn't look at molecular levels or physiological effects, but because it would make sense that if you're not sleeping well or having proper sleep quality during the night, that's what would cause you to have excessive daytime sleepiness. But this study kind of unveils that may not necessarily be the case. And so the questionnaire itself, the Epworth Sleepiness Scale, measured daytime sleepiness based on how likely someone is to doze off during specific activities during the day, such as driving, having lunch with a friend, watching TV, etc. So the sleepiness that comes, that would make someone doze off during those activities is definitely something that would be interesting to look into.
If I can drill into that a little more, I think, or what I took away from part of your presentation was that there was a correlation there was a correlation between daytime sleepiness and poor sleep quality, but obviously a much smaller percentage. reported daytime sleepiness. So if I can try to restate that, and you can tell me if this is correct or not, is of people who do have daytime sleepiness, they probably a large, maybe all of them, or a significant number also had poor sleep quality. But the other way around, people who had poor sleep quality didn't necessarily have daytime sleepiness. Is that?
Yeah, exactly. So not all those who had daytime sleepiness were having reduced sleep quality, but a lot of them were. So that is most likely like the reason. But you know, there were definitely varying levels of daytime sleepiness because I used the cutoff from the questionnaire itself of a score of above 10 on the questionnaire indicates excessive daytime sleepiness on a standardized scale. But you know, because this study used no control group, the cutoff may be a bit different in an FSHD specific population, if that makes sense.
Mm-hmm.
But so all of these correlations would actually, like, my research was definitely hypothesis generating for future researchers. So you know, my research could be used as a jumping board for studies in the clinical setting, for sure.
Yeah. And Kevin asks, did the study check to see how many people were using sleep aids such as Lunesta or pain medications? And if so, how did that impact sleep quality and daytime sleepiness?
The study did. That was a question on the survey, determining how many patients were using sleeping medications or sleeping aids. I did not draw those connections because, you know, there were so many questions that I asked, so I really looked at, you know, which ones would be most relevant to look at connection wise. But it did ask how many people were using sleeping aids. Unfortunately, I can't remember exactly what that number was, but I do remember it was around 50% or less. It was a minority of patients that used sleeping aids. So actually, like, using sleeping medications or you know, things like melatonin or, you know, just natural sleeping aids could actually potentially be beneficial for FSHD patients, because we do see that a majority were experiencing reduced sleep quality.
Okay. Question here from Larry, might be a little bit outside scope, but I'll ask it since you've thought a lot about this issue. But is there, in fact, anything that helps for people who are experiencing extreme fatigue?
This is, I mean, that's of course not what my study was focusing on, but I'd say, like, that's really something that would be specific to each patient, because FSHD is so, like, it affects each patient wildly differently. But if a patient is experiencing extreme fatigue, that's definitely something to bring up to a doctor, I'd say, because doctors would definitely have a better answer than I do, because, you know, that's what they're trained to do.
Yeah. I might mention last year, I think we had a webinar on sleep and getting a better night's sleep. So you might want to look that up. I think generally people would say, you know, before you reach for a bottle of pills, there are a whole lot of things you should try, starting with good sleep hygiene, regular sleep habits, looking at your sleep environment, you know, looking what happens before sleep to kind of, you know, like a lot of people now say, make sure you reduce your screen time before you go to bed.
That's an interesting finding,
etc. So anyway, do look it up. It's on our YouTube channel. We had a blog post about it. So there's some great suggestions there. And I think that also addresses a question that Manav Goel asked, is what are recommendations on improving sleep quality? So I think that webinar we had last year would be helpful there. And let's see. Oh, did you determine from your survey the percentage of patients who are using like CPAP or bipap ventilation? Was that a question?
That was a question. Again, I don't have the numbers right in front of me because I did have a lot of data that came from this, so I haven't memorized all the percentages. If the person who asked this question is interested in knowing that answer, they can definitely reach out to me, and I can like answer that question because I do have that data, just not right in front of me.
Would that data be included in the publication that you're preparing, do you think?
It depends, like on research journals are very specific about their word counts and their formatting. So it just depends on the relevance of that specific data point in the scope of the whole study.
Sure, right. Actually, one thing I might suggest is you might want to share the kind of the raw data from the surveys, the survey results, right over our website. So, you know, even if you can't put it in a publication, people might be very interested in seeing what the results were from the survey.
Yeah.
Let's see. Here's a question from Amy. Thank you so much. This is a great project and a subject of great interest to me, since pain while trying to sleep was my first symptom of FSHD and led me to a diagnosis. Have you considered gathering information from patients on what strategies they use to minimize pain while sleeping? I'd love to hear from other people's strategies. I have a bunch of my own, aside from prescription medicines.
That's something that my research was focusing more on, like what was really happening in sleep and during the day in terms of sleep quality and daytime sleepiness, and less on what patients were actually doing to better sleep quality. But I think that, I'm sure that that's something that could be done in the future, maybe in FSHD groups. I know there are a lot of support groups on Facebook where people exchange strategies. And perhaps that could be a future blog post that the FSHD Society publishes. I can share my strategies because I did have, as I mentioned, I did have some trouble sleeping in the early stages of my diagnosis. I try to, have some time before bed where I really relax and tell my body that it's time to go to bed, and I find that definitely helps. And treating pain right before bed is also really helpful. For example, using a heating pad during sleep, I find always helps kind of loosen my muscles and helps my pain, which actually does help me sleep. I don't know if it's something related to the heat, but it's most likely because it does treat that pain. And then I also find that melatonin is really useful in helping your body to understand like when is bedtime.
That's great. Thank you. A question from Manav. Did you do a correlation with lack of vitamins or minerals in the patient body? Were there questions relating, I guess, to supplement use or nutrition?
I did not do that. I think it would be really interesting to actually analyze that in the clinical setting. Actually, I saw that question on the screen. The way that it was phrased, it would be really interesting to actually measure vitamin and mineral levels in patients and then correlate that with their clinical sleep quality. Because in some of the studies that I researched in my preliminary literature review, I saw that there was some mention of mineral and vitamin imbalances, and that having an effect on sleep. So if this could be further research, that could actually have really interesting implications.
Rick has a question. Can you please explain what nocturnal hypoventilation is?
Of course, yeah. Nocturnal hyperventilation is a disorder that happens in sleep. It's breathing related, and it's when during sleep there's not enough gas exchange. So as you may know, your body takes in oxygen and outputs carbon dioxide, and that's how respiration and breathing works. So nocturnal hyperventilation is for one reason or another during sleep. There's not enough oxygen being taken in and not enough carbon dioxide being put out. So therefore, when you wake up, you actually have too high levels of carbon dioxide. And this in studies is typically measured through a system called transcutaneous keptometry, which is where they kind of just put, like in most cases, like a patch or like a needle in the skin, and that measures, you know, the rate of gas exchange in sleep. And that this disorder is kind of falls under the umbrella of sleep disordered breathing, which has been found to be pretty common in FSHD. This was kind of the main focus of my literature review. And in different studies, there have been different numbers of percentages found of patients with sleep disordered breathing. Like in one study, there was 58% of patients, and in another study, there was 31% of patients. But definitely nocturnal hyperventilation is pretty common in FSHD, and it's not always to a large extent. So some patients may actually have nocturnal hyperventilation without knowing it.
Thank you. Here's a question from Graham. It says, I suffer with FSHD and get woken up with joints in my back cracking and popping. Is there anything I can do to help prevent this pain? And is this common with FSHD?
I mean, that is like, of course, pain is known to be a very common symptom in FSHD, and a lot of patients experience different kinds of pain and in different areas of the body. And unfortunately, there's not really like a universal solution that has worked for everyone in terms of treating pain. But really, I'd advise you to just try a lot of different things, because there are a lot of resources out there. And I know a lot of patients that try a lot of different things that work for them individually. And maybe perhaps, you know, trying to treat that before it wakes you up during sleep would help with not only the pain, but also helping you stay asleep during the night.
Yeah, I think a lot of people have a lot of discomfort when they first wake up, and they may be very stiff. This is not just with FSHD, by the way. Just getting older does it to you. But people I've heard have like morning routines where lying in bed, they'll do a series of gentle stretches and just things to kind of get the body able to move again. So, and that's something, you know, maybe to talk about with a physical therapist or a physiatrist who might have, or you know, who might have some early morning, you know, exercises and things that you can do to address those types of issues. So I was wondering, because the survey, it's been many months since I've seen it myself, and I'm wondering if there might be, it felt like the questions on there might be really helpful for individuals to kind of self-monitor and increase their own awareness of whether they have poor sleep quality or if they have daytime sleep, because you know, often you're just going about your life, you don't realize that you're actually exhibiting symptoms of something. So can you quickly review, like, you don't have to go through all the questions, or what are some typical things that might help someone self-monitor for poor sleep quality?
Mm-hmm. Yeah, so thanks for bringing that up, because again, like sleep quality isn't always measured through, you know, how sleepy you feel during the day, and this study is definitely an example of that. So the questionnaire that I used to measure patients' sleep quality was called the Pittsburgh Sleep Quality Index. It has 18 questions, and some of the questions have, you know, subsections. Some of the questions and most of the questions kind of ask the respondents to rate from 0, 1, 2, 3, 4, you know, 0 means never, and 5 means, you know, like every day. It kind of asks questions like, how often, like during the past month, how often have you woken up during the night during the past month? You know, how often have you had pain during the night? And just kind of questions like that, where you kind of like Likert scale type questions. And then there's a whole complicated formula that actually calculates the score. But those questions are actually really beneficial in determining your sleep quality. So maybe that's actually something that could be published as kind of a follow-up to this webinar, is some of those questions, so that even if calculating the score is a whole process in itself. So that's not something that patients, like, if you're not comfortable with statistics and math, maybe leave like the scoring alone, but kind of tracking any changes in actually the responses to the questions could actually be pretty beneficial for showing your doctor on your next checkup, like, here's last month's results and here's this month's results. Like, are these differences, like, does this mean that my sleep quality is deteriorating? What can I do about it? So maybe that's something that we could send to patients as a resource.
That would be great. We could post it on our site and people can do like a self-evaluation and share that with their doctor. We'll talk about that afterwards, and that'd be great. So let's see. We have some fan mail for you. Both David says both the study and the presentation were fantastic. As a parent of 3 kids, several years older than you, please tell your parents they should be incredibly proud of you. Such poise, thank you, and keep up the great work. And let's see. Rick says you read a lot. There was a test related to nocturnal hypoventilation. Can you can you repeat what that test was? Is it the cutaneous or
yeah, it's called transcutaneous keptometry. It's not something that you can just order off of Amazon. It's something that needs to be like done in a doctor's office. But it's typically done during a sleep study because it's a pretty specialized instrument to relate. Yes, transcutaneous keptometry. That's what it is. And so yeah, that is something that that is a test that's used to measure nocturnal hyperventilation.
I think Bill Corinne had a question. He said, how did you correlate fatigue factors in regard to sleep? I guess he's saying while they may be correlated, then again, there could be non-FSHD factors that can cause it.
Yes, so the fatigue was daytime sleepiness. It was measured in the form of daytime sleepiness, and that was another standardized scale called Epworth Sleepiness Scale. This is similar to the Pittsburgh Sleep Quality Index, but measures daytime sleepiness. And so the 2 questionnaires, the Pittsburgh Sleep Quality Index and the Epworth Sleepiness Scales, were what I used to measure the sleep factors, so sleep quality and daytime sleepiness. And then all of the other variables that I asked on the survey were under demographic and clinical sections. So I asked all kinds of questions, including age, gender, like whether someone is using what mobility aids someone is using, whether people are using sleeping medications, whether they have pre-existing sleep conditions, and then I use statistical tests to correlate all of those demographic and clinical questions with the questionnaire scores.
Great. Let's see. I guess there are a few comments in the Q&A section. I sometimes feel tired and can fall asleep anywhere, and the harder I try to stay awake, it seems to get worse in restaurants, in the pub with guests around. Is there anything to try I can try to do to stay awake?
I mean, I think this is, again, a kind of patient-specific solution where you find something that works for you. But again, it may be that you're actually experiencing reduced sleep quality, and that is what's making you feeling that fatigue during the day. And of course, FSHD causes a lot of fatigue itself. because, just the nature of this disorder. So, trying to get some better sleep, sleeping longer hours might be beneficial. I think that's most likely the best solution.
Right. I also understand that sometimes something that's not uncommon with FSHD is that the expiratory muscles, the muscles that push the carbon dioxide out of your lungs, are more affected. And so what can happen over time is that your blood carbon dioxide levels start to rise. And this can be insidious. You might not be aware of it. You might not, you won't be short of breath or anything like that. And unless you specifically do a measurement of blood carbon dioxide, it can kind of creep up on you and manifest as fatigue, even though you're sleeping 8 hours a night, or you don't think you have. So that's so if you're experiencing daytime fatigue, we always suggest talking to your doctor about it and maybe getting a pulmonary function test, getting those blood gases measured to see if that might be a cause.
Yeah, I'd love to expand on that actually. That's actually pretty much the concept of nocturnal hyperventilation, when your carbon dioxide levels start to rise in the blood. And my study found that persons who are using ventilatory support during the night, including CPAP, bipap, and oxygen, had no statistical difference in daytime sleepiness from those who were not using ventilatory support. So if you're actually experiencing, breathing complications, which, as June mentioned, have been related with FSHD, especially because as the chest muscles weaken, this can kind of affect the lungs by pressing down on them and the like. So maybe ventilatory support might be something to look into, like using oxygen during the night, or another form of ventilatory support if the case is that you are having insufficient gas exchange.
Right. And not only oxygen, but also the bipap. Some people are prescribed a CPAP, which kind of it's a constant air pressure and supposed to increase your oxygen intake. But for FSHD, bipap is recommended. That's a two-way. It kind of pushes in, but also sucks out, and it helps with the expelling of carbon dioxide. That's also something to be aware of and talk to your doctor about. So I think we're getting close to the end of our time. We have question. Are you planning to do any follow-up studies yourself, since you have nothing else to do as a senior in high school?
I'm very interested in STEM fields, especially not only because I really like science, but also because I realize the potential of science and technology to cure disorders like FSHD. So I'm very interested in research. As I mentioned in the beginning of my presentation, I just did an internship last year with the LEC lab, characterizing DUX4 sequences of FSHD. So I'm definitely going to keep on the research track in the future. And that's definitely something that's on the horizon for me.
That's just terrific. Well, we're near the end of our time, so I'd like to invite Beth back to make some final announcements. Thank you.
Wow, Heloise, that was fantastic. You are truly amazing. And if I might, I'd love to share some of the accolades that were in our chat today. Nancy says, this is an awesome study. Congratulations, Heloise. Greg says, as a participant in your study, I want to thank you very much for the excellent work you have done. Heloise, you are going to do some great things in life, which you already have. So you have a fan base. So just know that they're out there. But again, Heloise, thank you for being with us today. You're the best. And I want to thank everyone for attending our FSHD webinar today. And the special thanks to Heloise, of course, for her excellent presentation, for delving into this super important issue that affects so many of us and our families. So Thanks again, hun. Our next FSHD webinar is Thursday, September 23rd at the same time, 1 p.m. Eastern. Our speakers will be Isaac and Ora Prilatensky, who you may know. They'll be speaking about the mattering effect and how feeling valued and adding value can actually shape our lives. So please join us next month. And please visit our website event calendar for all of the upcoming chapter, wellness, and educational events. Again, thanks everyone for joining us today. Special thanks to Heloise, and we will see you next time. Thank you. Bye-bye, everybody.
Thank you. Bye.